first of 4 lectures this morning, What's New in My Specialty. Dr. Chad Gonzales is our first speaker. Chad's a local boy. He is from Roy, Utah, and he's the first of 2 Aggies who will be speaking this morning. He went to Utah State University and is an Aggie there. Was a graduate in 1995. Had a lot of honors when he was up there, a lot of scholarships, and did some summer research projects up there. Then went as far south as the University of Utah for his medical training. Was there from 95 until 1999. And then did an internship and residency in internal medicine, stayed in Salt Lake for that, and then headed east and made it as far as Iowa, and did 3 years of his GI fellowship in Iowa, both in GI and hepatology in 02 and 05. And then we've been lucky to have him back here at McKay. He's been, for the last 5.5 years, on staff, gastroenterologist at McKay Hospital. Has an interest in inflammatory bowel disease, functional GI disorders, and liver disease. Been president of our Weber County Medical Society over the last year. I think a real rising star here in town. And I'd like you to welcome Dr. Gonzalez.
Can you hear me? Well, I'd like to thank Dr. Brown for those kind words, and thank the organizers for allowing me to come today and present this talk. And I'll go ahead and get started. So we all think about being here right now in Hawaii. Be nice. I have no conflicts of interest to disclose. And these are the objectives of the talk. I wanted to talk about an under-recognized problem, complication of narcotics, narcotic bowel syndrome. But first present a couple cases. The first case is a 30-year-old gentleman, or woman, that I was asked to consult on in the hospital with a prior history of recurrent acute pancreatitis. And these were real episodes of pancreatitis, I think, that any of us could diagnose. She had 3 episodes occurring over the course of 1 year. And I saw her about 2 years later. She was admitted with chronic, constant upper abdominal pain, nausea, vomiting, and constipation. And over that 2-year period of time, she had had multiple negative tests, CT scans, MRCP, upper endoscopy, colonoscopies, blood tests, and importantly, during this length of time, she had normal pancreas injury tests. Amylase and lipase were completely normal. And I was asked to see her as a consult in the hospital. The presumptive diagnosis is that she has chronic pancreatitis. I think most of us recognize once you have that, you always have it. You know, it's always pancreatitis if you have abdominal pain. From her history, she was taking about 60 milligrams of Percocet a day and 50 micrograms of fentanyl a day. And my first interaction was seeing her in the room. I heard, that she had 10/10 pain. I walked in the room and she was emailing and texting her friends and smiling and laughing with her mom. And I said, "How was your pain?" She said, "It's the worst pain that I can imagine." And so I thought, okay, there's just there's a disconnect here. Worst pain ever reported, and you're texting and laughing with your mom, and very benign exam. The next case was a 55-year-old unfortunate gentleman that had his gallbladder removed because of right upper quadrant pain. And it was one of these surgeries where no gallstones, mildly abnormal HIDA scan, everything else was pretty unremarkable. And had it removed, and no surprise, did not get improvement in his pain. This led to an ERCP with the presumptive diagnosis of sphincter of Oddi dysfunction. I think a lot of you have heard of that diagnosis. Spasm of the sphincter of Oddi. So had an ERCP, had a sphincterotomy, and everything looked normal on the scan, put a stent up his bile duct, and he felt better. So the idea was, well, he has sphincter of Oddi. We've just cured that problem, or not cured it, but helped it. Let's send him to a sphincteroplasty. So had a surgical sphincteroplasty performed, and unfortunately developed severe acute necrotizing pancreatitis. That was about 6 years ago. And and then presented, with chronic, unrelenting, severe, constant right upper quadrant abdominal pain after that one episode of pancreatitis. So much in the way of symptoms, he couldn't eat, had a chronic, direct jejunostomy feeding tube, and took very little by mouth. His workup over the years were multiple negative studies. Blood tests, pancreas tests were never abnormal again. CT scans, MRs, MRCPs, endoscopic ultrasound, ERCP, all of it normal. No evidence of calcific and fibrosing pancreatitis whatsoever. His presumptive diagnosis was chronic, non-calcific, non-scarring pancreatitis, and the recommendation from the doctor before he came to see me was a total pancreatectomy and an islet cell transplant to remove pain. And so I said, whoa, wait a minute, you become a brittle diabetic instantly. If if the pancreas transplant, the islet cell transplants fail, you become a brittle diabetic, and this is an incredibly invasive procedure to control pain. He was taking 90 milligrams of OxyContin and 80 milligrams of oxycodone. And I remembered from fellowship, this was quite a while back, this case was. I remember from fellowship that we had a similar case, incredibly unfortunate woman who was having chronic pain, no organic explanation, who had an indwelling portacath that she mainlined MSIR, a fast-acting MS morphine, and Zofran every 2 hours for a year, and came in with horrible pain. And I remember my fellowship director saying, Chad, your grade rests upon your ability to tell me what narcotic bowel is and do it by tomorrow. And I thought, geez, I don't know, you're sending me on a wild goose chase because I looked that up for you about 2 weeks ago. You forgot. But I've looked this up and I didn't find anything, but I'll try again. So I wanted to talk about just that, narcotic bowel. So patient number 1, diagnosed with narcotic bowel, that I was sure of. She agreed to taper and she discontinued her narcotics and her pain nearly went away. I say nearly because there's a little bit left over. And to this day has not been readmitted to the hospital. Patient number 2, I suspect he had narcotic bowel. He agreed to a less invasive treatment course and agreed to go on into rehab. Was treated with Suboxone. I added Disipramine, Ativan, Celexa, had to meet with psychiatry, and his pain improved. He went from 10 over 10 pain all the time to a few days with no pain whatsoever, off of narcotics. Nausea, vomiting, constipation resolved, and he was able to eat by mouth for the first time in a year and a half. Problem was that his psyche was so damaged from the whole experience that he feared pain, had recurrence of pain, got back on narcotics, and I referred him to the Mayo Clinic in Scottsdale, Arizona, and I haven't heard back. And I said, get a second opinion before you do any surgical procedure. I don't think it'll help you at all. So, common features of these patients: chronic pain. They both have functional GI symptoms, multiple negative evaluations across all the spectrum: blood test, imaging, endoscopic procedures, and surgical procedures. And most importantly, a lot of frustration on my end, physician and on patient frustration. So this data was presented yesterday. I'll skim over it. Narcotic prescribing in the U.S. Of course, we know that the United States uses most of the world's opioids. We keep a lot of countries in business, developing these medications, and that retail sales of these medications have increased exponentially. And then in most metropolitan areas, narcotic analgesic-related deaths exceed deaths of those from illicit drug use. And of course, we know that more of these drugs are prescribed to younger and healthier patients with non-malignant pain. And unfortunately, a lot of them are getting it for functional GI disorders, which is, I believe, just a disaster. And the narcotic prescribing problem here in Utah is that we're in the top 10 states of non-medical use of prescription drugs. And in 2006, of course, there were 307 deaths from non-illicit drug use, most of those involving narcotics, and a bunch of those were patients who, actually had a prescription for the drug that killed them. And I think we all know patients and even family, or family friends that have died from overdose. So, and we know that ER encounters for methadone and narcotic drug use has increased from what we heard yesterday. So it's a big problem, a huge problem. So what is narcotic bowel syndrome? And this is why it was hard for me to find anything, because there was nothing published. I mean, I think we knew that narcotics could affect the digestive tract, but we didn't have hard data to review. So first reported in the United States 25 years ago, in China about 15 years ago. And up until about a few years ago, there were very limited studies, 4 case reports on Medline in 20 years on narcotic bowel. We know it's a chronic or intermittent colicky abdominal pain, worse when narcotics wear off. Narcotics seem to be helpful at first, but over time you develop tachyphylaxis and increase your narcotic dose, and then pretty soon you've got this sort of vicious cycle. Adverse side effects that I'll explain, enhanced pain and delayed motility. So Douglas Drossman's group at University of North Carolina in Chapel Hill, Doug Drossman is the guru for functional GI disorders in the United States, and he is one of the founding members of the Rome working group that put together the Rome criteria for functional GI disorders, the Rome 3 criteria, or the newest criteria. And he has a GI motility and functional GI disorder clinic that receives consults from all over the world. And he got together with some, I'm sure, very bright researchers he works with and said, we know narcotic bowel exists. Let's put together some basic criteria so that we can then use that as a launching point to adequately plan trials and outcome measures and study this more in depth. So he proposed that the diagnostic criteria, his group, for narcotic bowel include chronic or frequently recurring abdominal pain that is treated with acute high-dose narcotics and chronic narcotics, and all of the following. Importantly, that the pain worsens or incompletely resolves with continued or escalating doses of narcotics, and that there is a marked worsening of pain when the narcotic wanes, and it gets improves when narcotics are reinstituted. Sort of this soar and crash, and I think we've all seen that with our patients. It works, and then it goes, as soon as it wears off, they're having horrible pain. There has to be progression in the frequency, duration, and intensity of pain over time. So you have to sort of say, well, it's getting worse, not getting better, even though they're escalating the dose of their narcotics. And most importantly, the very important caveat is the nature and intensity of the pain is not explained by anything else. These are people who have multiple negative studies without any evidence of active structural disease, inflammatory bowel cancer, that would explain their pain. And some of these patients that I see have had chronic pancreatitis, or not chronic, but acute pancreatitis. But there is no structural evidence of chronic pancreatitis at all. So what are physiologic effects of opiates? I think most of you know this. On stomach duodenum, the pharmacologic effect is inhibition of gastric emptying, increased motility, increased pyloric tone, and enhanced gastric acid secretion, with the clinical effect being nausea and vomiting and anorexia. And I think if you've been on narcotics before, you know that it messes you up. I had narcotics for 5 days after knee surgery. I was a wimp, I thought I could handle some Tylenol, codeine, and I called in, and Lortab hadn't worked. I got Percocet, and then realized, I can't sleep, I'm nauseated, I can't go to the bathroom, all these bad things are happening, and this is no good, and I got to stop them, And so these things these drugs do affect the digestive tract in a big way. On the gallbladder, biliary tree, the pharmacologic effect is contraction of the gallbladder, relaxation of the sphincter of Oddi, or spasm of the sphincter of Oddi, decreased secretion. So we know that patients can develop biliary pain and delayed digestion. In the colonica, in the large bowel, small bowel, we know that these opioids, narcotics, increase tone, decrease transit time, increase absorption, decrease secretion, with the end effect being constipation, delayed digestion, bloating, distension, and abdominal pain. So what are the potential physiologic mechanisms for pain facilitations in patients who use opioids? Well, I think it's important to recognize and accept that narcotic analgesics can actually cause or aggravate pain. And for some that haven't really thought about that or observed it, I believe that's true. They can actually cause pain. Opioids, act on receptors in enteric neurons, can act on enteric neurons and result in reduced GI and biliary motility and secretions, as I've talked about. There are three putative mechanisms that obviously need to be studied more in depth to explain pain. There's a bimodal excitatory inhibitory opioid regulation system with preparation of activation of excitatory pathways over time. You develop pain, increased pain. There are counter-regulatory mechanisms that result in pain facilitation via dynorphin and CCK activation and direct glial cell, spinal cord glial cell activation that increases pain. So this is that bimodal opioid modulatory system. And I think they know from studies, in vitro animal studies and in some limited human studies, that low-dose opioids in the 1 to 10 nanomolar amount mask inhibitory effects and cause hyperalgesia in studies. And they know in high-dose opioids mask excitatory effects and cause analgesia. But over time, what we observe is that with chronic opioid use, that you can develop tolerance to the inhibitory receptors, opioid receptors, and develop sensitization of excitatory receptors and develop paradoxic pain. I'm going to pass over that. That was just a slide showing all the factors that can directly affect the glial cells and enhance pain. And there are multiple factors that can. Pro-inflammatory cytokines and viruses and other glial cells that come into play and activate. So obviously we don't understand those mechanisms well enough, but they're being actively studied. So what do we observe? And I must say that I observe this interaction at least once a week. And at points in my career in the last 5 years, it's been a lot more frequent than that. And I live from one vacation to another. Otherwise, you just go crazy because people come in and they are mad, frustrated, and they're waiting to take it out on someone. And no one can figure them out. You hear the story as well. So patients come in, and they may have bona fide pain. Post-operative pain, inflammatory bowel, whatever the pain is, and they get on narcotics, and some of these patients develop narcotic bowel syndrome. And this leads to multiple negative evaluations. Patients become frustrated. We know that it increases healthcare utilization. Multiple ER visits. So many so that I've counted, dozens in patients. In 1 year, dozens of ER visits for pain. There's healthcare and societal pressures. And then this sort of erupts into this furor medicus that I think people could appreciate, this cycle of intense, misdirected medical activity. And then frustration. Physicians are like, I just can't handle it. You need to go see someone else. And then they develop this maladaptive therapeutic interaction with patients, physicians, hospitals, insurers, everybody. They get more narcotics, and it's this vicious cycle, and it just cycles over and over again. We ran blood tests and did MRI scans, took stool samples, and performed a colonoscopy, and we've determined that the bloating sensation you're experiencing is fat. Now, I know we think this, but it doesn't go well if you say this, because they come to me and say, my doctor told me I was fat, or they say, my doctor told me I was crazy. Now, I know you didn't say that outright, you are crazy, or you are fat, but that's what they hear. I've had patients call my office manager. I'm talking to Dr. Gonzalez's boss. He told me I was crazy. And I get back on the phone, I'm like, I really don't use those words that way, and how can we patch this over a little bit? Let me talk to your mom who was standing there, and let me see if she heard the same thing. So it doesn't go well. But I know we think that, and weight has a big impact on health, and we'd like to say that. So treatment options for narcotic bowel syndrome. I wish I could tell you that it was easy to treat this, that we could prescribe something that could make it all go away, and patients could get dramatically better, but that's just not the case. And the most important treatment is a good physician-patient relationship, because what you have to do is explain to them that the pain is real, that you believe it is real, and that it's not, feigned or made up. And so you have to make sure that they aren't really, malingering, and they're not really drug seeking. They may be drug seeking, but they're not really there to get their narcotics and take it and sell some to their friend. So accept the pain is real. You have to provide information to the patients. I actually copy this article from Doug Drossman right out of the Journal of Clinical Gastroenterology, and I give it to him and say, read this. Get out your medical dictionary, call me if there are questions, but read this article. It's just that good. And the patients that have went on and been treated actually read the article and understood it, and it took a while, but they understood what the rationale was. So you have to explain the physiologic basis for pain, and if these are patients with functional GI disorders, you have to explain how you can have pain with having normal studies, how that can develop. How is that possible? That someone can have abdominal pain and every test is normal, and they've had their appendix and their gallbladder removed, and they've had laparoscopy. So you have to explain visceral pain. How can you get pain from here to here? The sort of gut-brain axis. Also have to explain what narcotics do to GI function. Explains why they're constipated and they're vomiting and they can't eat and they've lost weight and they can't sleep. Have to discuss your rationale for withdrawal and present the withdrawal program. Elicit the patient's concerns and expectations, which is very important. They're going to say, what am I going to do when I have pain? What are you going to do for me? Where am I going to go? And you have to make a plan for that. Well, if you get pain, this is exactly what you're going to do. This is who you're going to call. You have to gauge the patient's willingness to undergo the program. Some of them just say, yeah, I'll do it. And you just know they're not going to really do it. And you have to discuss a treatment plan with a family member. And the cases I've done, I actually called the physician and said, this is what the plan is, so they may call you about pain. This is what I've told them. And you have to do all this in 10 minutes. I've told them straight up, listen, I have you slotted for 30 minutes today. I didn't think we were going to have this discussion. You're going to have to come back again, and we'll have more of this discussion. You read the paper, come back, bring your family, everybody that's going to be invested in this with you so that I can explain it to them, because I just don't have time to explain it over the phone to everybody that you want me to explain it to. So, what do? I get these patients on a form of antidepressant. All right? Now, I don't tell them I'm treating their depression. I tell them straight up, I don't really treat depression. I'll send you to a psychiatrist, but I don't treat it. What I do use is a tricyclic antidepressant because these medications, I believe, modulate visceral pain, nerve-related pain. That's what I explain to patients. And if they're depressed, of course, we treat that as well. Now, Doug Drossman, the guru of functional GI disorders, he believes in these, in these secondary amines, dicipramine, nortriptyline, because of fewer side effects. I have personally not had as much success with these drugs. I use amitriptyline, and I tell them about constipation, dry mouth, and all those issues, and difficult and somnolence and sleeping. Duloxetine, venlafaxine. I saw a patient the other day that her diarrhea and irritable bowel pain went away with venlafaxine, and her doctor was brilliant. Brilliant. He saved my life. No one else could figure it out. So these drugs do work for some patients. I start them right away, right before we even consider taper. I have seen patients that I've been able to control visceral pain, functional GI pain, very, very nicely with those medicines. Of course, when you start withdrawal, when you start a withdrawal program, they need to have sympatholytics, clonidine to counterattack the withdrawal symptoms that they develop, anxiolytics as well, Ativan or lorazepam or clonazepam. I start spasmolytics. It's a drop in the bucket for them. I try it anyway. Drugs like hyoscyamine, dicyclamine. I start those drugs. In fact, I give them out on almost every encounter of pain without explanation. I give out hyoscyamine, and hoping that improves their abdominal pain problem. They need a cathartic polyethylene glycol solution aggressively right at the beginning. If you buy a bottle of Miralax at the store and it says a capful, never works. Tell them they can take 2 capfuls 3 times a day, or dump the whole thing in a pitcher of Gatorade and drink it all at once. Just make sure they get enough of it. If they're constipated already, you just have to give enough of it. And giving the little capful is not going to be enough. Consider lubiprostone. That's a drug that I think a lot of people are familiar with. Amatiza. In this setting, I'm not sure it's going to help much, and it hasn't been proven, at least for treatment of narcotic bowel syndrome or opioid-induced constipation. There's psychologic treatment as well that's very, very important. Cognitive behavioral therapy, relaxation methods. I send people to chiropractors, hypnotherapists, acupuncturists. We have a couple people. I tell them, it may not help your bowels, but boy, I think you're going to feel better. The rest of you will, your mind, body, everything's going to just be better. All right? And most of them feel that way. And some, not very many, but some felt like it helped their abdominal pain. Future therapies, alvimopam, a drug, N-methylnaltrexone that just got approved for treatment of narcotic-induced constipation in patients with malignant, problems with and atypical antipsychotics. So I'll be the first to admit there needs to be a lot of research about this problem, and the future is really wide open, and there hasn't been a lot of studies. I mean, this is there aren't government people knocking down on the door waiting for people to come out and say, let's do this research and give you money. It's just one of those things that doesn't have a lot of interest as far as funding. So narcotic withdrawal protocol for narcotic bowel syndrome. Important, as we've talked about, to make a diagnosis, validate pain, discuss the pathophysiology, and then, you come up with a plan, starting the PEG, the tricyclics first, adding in Ativan and clonidine, and then withdrawing, tapering their dose of narcotics. The one patient self-tapered. The other patient I've seen fairly recently, we actually had a pain specialist in drug addiction help us with Suboxone. So issues that may interfere with a successful outcome: patient negotiates to go back on narcotics. Anxiety toward treatment failure, ambivalence, malingering. Patients rapidly taper or abruptly withdraw narcotics. That's a big problem. Oh, I'm gonna, I don't have a month or two to I'm just gonna stop them, and that's always going to fail. And very big problem, patient seeks drug elsewhere. The ones that come to see me, if they get drugs anywhere else, there are no second chances. They are fired from my clinic, not fired, but they fire me. I just drop them from my clinic. ER narcotic treatment is a very poor prognostic sign. So conclusions. Narcotics are one of the most prescribed medications for chronic non-malignant pain. And these patients, and functional GI pain, to be honest, a lot of patients get narcotics for functional GI disorders, and it's really bad. MBS, narcotic bowel syndrome, occurs in patients who have increased pain with GI dysmotility. It can be diagnosed, I think, if you have a high index of suspicion. And the cornerstone of care really is an effective relationship with doctor-patient relationship. So, though Dr. Zapata was a talented proctologist, his dyslexia occasionally proved problematic. I had to throw up a joke about GI docs. So, any questions? It is, and I see, and the comment was that it's a big problem, and see it a lot in GI surgical practice. Patients who want their gallbladder out and are mad because, doing the right thing, you explain that you may not get better in that. And it's a big problem, it really is. And those patients, I see a bunch of those patients, and they deserve a trial of non-narcotic, obviously, medical therapy. And so I always explain to them, I'm going to put you on a tricyclic antidepressant. I'm going to aggressively manage your pain. And a bunch of those patients I salvage from gallbladder surgery. And then if they fail that, I say, okay, let's get the gallbladder out of the equation. All right? And then very importantly, what happens is patients come to me, well, he must have sphincter of Oddi spasm. Must be that. Must be sphincter of Oddi. He needs an ERCP. And that's where I'm very careful at making that diagnosis. Because, you do an ERCP, you give him pancreatitis. Do I have another time for one more question? Okay. Anybody else? Okay. Thank you very much. And good luck managing these patients.